Afternoon, everyone. It's a pleasure to be with you this afternoon. Today's topic is recurrent pregnancy loss. So, this is one of the most challenging disorders of pregnancy we all face. It will be frustrating for both the obstetrician and also for the family if there is a loss. But at the same time, if it is a successful outcome, it will be the most satisfying experience for us, and it will be a moment of joy for the entire family. And another thing is, in this condition, we'll be doing a lot of tests, and the treatment protocol is also stabilized, established. But sometimes, in spite of it, sometimes we'll not be able to pinpoint the cause for it. Moreover, there'll be a lot of anxiety and expectation from the family, so which they will pass on to us. So it will be very mentally challenging for us also during this journey with the mother. So they will be asking whether you can give guarantee for this time. So that will be very difficult thing to answer them, because all the tests sometimes will be normal. We will be giving treatment. We have to focus on one thing, that is, we are giving treatment. It is like when we compare with the seed and the soil. The seed here is the embryo and the soil is the uterus. So even though we add water and put manure, if the seed is defective or the soil is not fertile, the yield is not going to be all right. When the seed is quality is good and the soil fertility is improved, then when we add water or manure, then the yield or the harvest will be very good. Same thing we need to look at this in this situation. We are not improving the composition of the oocyte. So we are just giving treatment by way of medicines and some procedures. So why is it important to improve the quality of the oocyte? For that we need to see what happens. So let us see the fate of the conception. So if 100 conception occurs, 60 of them they get aborted in the preclinical before it gets confirmed only. So 30% implantation failure and 30% very early pregnancy loss. So they may recognize it as a delayed periods, or they may think it is just a menorrhagia, but actually it will be a preclinical pregnancy loss. After confirmation, 10% again they get miscarried. So only 30% of the conception they go for live birth. So now we have to focus our attention on how this conception occurs. For this, the embryo is the dominant element to initiate the reproductive process. The embryo must be viable and it must be able to have the ability to give the specific signal to the endometrium. This is very important. Similarly, the endometrium must be receptive and selective to retain the viable or healthy embryos. So in this, progesterone is the ultimate controller, but it has other helping agents like NK cells and dendritic cells and Th1 and Th2 systems. That is the implantation. The cells near violet color, that is the dendritic cell, and the red one here, that is the natural killer cells. This NK cells, it prevents trophoblastic invasion, and the dendritic cell, it helps in the preventing the rejection of the embryo. So both of them, they have opposite effects. The NK cells prevents the invasion of the trophoblast, whereas dendritic cell has the opposite effect. These two maintains the balance so that the pregnancy is continued. And similarly, the TH1 response, it helps in the implantation, and the TH2 response, that helps in the maintenance of the pregnancy. So all this is controlled by the progesterone. So what we need to know now is, if for the embryo to be viable, embryo to be healthy, the oocyte quality must be good. Then only there will be oocyte maturation, ovulation, fertilization and implantation to go on for a healthy pregnancy. What happens now? Nowadays we see for the past 10 to 20 years, there is lot of increase in the infertility incidences and also increase in the miscarriage rates. WHO also done study, survey in more than 74 countries, and they have found globally also fertility rate is going down, and out of the many causes, it is the lifestyle change that is supposed to be very important, because we also know that our change by way of diet, resorting to fast food cultures, and also sedentary activity, change in the sleeping pattern, and stress has become part of our life. And what has this to do with this? This increases what is called as oxidative stress. Then this oxidative stress is actually, it is a normal function to get rid of the toxins from the cells. But when it becomes more because of this increase in the oxidative stress, what happens? It attacks the normal cells, especially the DNA, and enhances the apoptosis. So this is what happening, so that the oocyte quality is decreased, and increase in the incidence of polycystic ovaries and endometriosis. So the oxidative stress is more when the maternal age is advanced, and also when there is extremes of weight and environmental toxins. So we need to know the oxidative stress must be reduced. For that we have this antioxidants, vitamins and minerals. They offer extra electrons so that they prevent the healthy cells from getting into atresia. So we need more of antioxidants like vitamin A, B, C, D, E, zinc and selenium. All those things we need just because to increase the antioxidant levels. If the antioxidant levels are increased, then the oocyte quality will be more. And this can be done by way of diet and also supplementation. Diet, especially ovulatory infertility is more because of taking direct sugar, that is simple sugars, trans fat and more of salt. This has to be replaced by taking more of plant protein, complex carbohydrates, good fat, fiber and vitamins and minerals through diet, and also doing exercises. All these things will help in improving the antioxidant level. So that studies also have shown supplementing micronutrients preconceptionally, it helps in increase in the conception and also the time taken for conception, and decreasing the malformation. So we know the oocyte quality, when it is decreased, it represents in a variety of situations, varying from depending on the degree. When it is very severe, it results in ovulatory infertility. When it is a little more milder form, implantation failure, early pregnancy loss, and the mildest one will be the congenital anomaly. So genetic factors. This is when the parental karyotyping is done, we see balanced translocation. When it is the Robertsonian translocation occurs, the parent will not be affected, but the offspring can express into trisomy. That is, the commonest will be the trisomy 21 Down syndrome. And when this happens, when we investigate a case of RPL, karyotyping for both parents are done. If it is positive, they go for genetic counseling, and later when they conceive, they go for Korean villus sampling or amniocentesis. This is anatomic causes. When the septate uterus is there, the longer the septum, it causes pregnancy loss. and when there is submucous fibroid impinging on the endometrium, that requires again resection. When there is synechia or adhesion, that also requires hysteroscopic resection. All these things are done through hysteroscopy, and the outcome is good provided good antenatal follow-up is done. Next one is cervical insufficiency or cervical incompetence. Here it is in the second trimester when there is no uterine action, the cervix is not able to retain the fetus inside. So this is diagnosed by the ultrasound scan. When the cervix length is less than 25 mm and the dilatation is more than 15 mm. At this stage, the cervical stitch is applied. This can be through McDonald's, which is commonly done, or else Shirodkars, which is not usually done. The other one is through abdominal route. It can be done. So when it is done through abdominal route, the mode of delivery will only be C-section. So when the cervical stitch is done as an emergency, when the cervix length is more than 4 centimeters with bulging membranes, the result will not be as equal as when it is done in an elective setup. Infections, bacterial vaginosis, listeriosis, torch infections and chlamydia, and this will be very less. Here also it is when the infections are detected well in advance and treated at the right time, then the results will be good. And then endocrine disorders, hyperthyroidism, this also causes, this is not that common, this causes miscarriage and premature labor. Hypothyroidism is more common. Here, even the subclinical hypothyroidism must be detected and treated, even when the TSH level is 2.5 to 3. Why? Because the hypothyroidism has detrimental effect on the neurocognitive development of the fetus. If it is very severe, it can land into cretinism also. And the other thing is very early supplementation of thyroxine in very early pregnancy. It improves the pregnancy outcome. Hypothyroidism is also a cause for ovulatory infertility. So they will be investigated before conception. Treatment with thyroxine before pregnancy itself gives very good results. And anti-thyroid auto-antibodies. This is very much high in RPL cases, whereas TPO antibodies, this is seen, this is predisposed them to hypothyroidism. Selenium supplementation will decrease the antibody levels. So diabetes mellitus, when it is uncontrolled, and this definitely has an effect on congenital malformation. So what we need is HB1AC before preconception. That is a very good marker to identify the malformation. And during pregnancy also, they must be followed very well. The fasting level less than 100 and postprandial around 130, 140. That should be, if that is followed, then the outcome is going to be very good. The AFI level will be adequate, and fetal weight, there will not be macrosomia, and most of the time the babies will not go to NICU. Otherwise, what happens, in spite of taking treatment, in spite of following with a diabetologist or physician, if the control is not good and the outcome is good, there will be perinatal morbidity. Polycystic ovaries, here there will be 40% chance of pregnancy loss. Why? Because of increase in the hyperandrogenism and hyperinsulinemia. This decreases the oocyte maturation and also decreases the endometrial development. And metformin supplementation significantly reduces the incidence of miscarriage. LPD, this is because of decrease in the progesterone level. This can happen because of decrease in the follicular development or decrease formation of progesterone by the corpus luteum, or the progesterone level may be normal, but because of deficient progesterone receptors, endometrium response will be dysfunctional. So the causes will be stress, because once there is stress, there is cortisol release. They will have a progesterone steal effect. So progesterone level will be less, weight loss and hyperprolactinemia. So how progesterone helps in maintaining the pregnancy? This has improves the endometrial receptivity and changes the causes the stromal cells into very good decidual cells, and it improves the circulation and oxygen to the endometrium, and at the time of implantation it reduces the contractility of the myometrium so that the implantation occurs smoothly. And the important thing is it produces PIBF, that is called progesterone induced blocking factor. It has two actions. One is on the NK cells. When the NK cell is action is lessened, then the implantation and continue is improved. Otherwise, in cases of RPL, the NK cells and the cytotoxicity activity will be very high. And the other action is the TH2. The TH1 response will be less and TH2 will be more, so that pregnancy will be maintained easily. And dydrogesterone is the latest drug and very effective. And the side effects are less because it has a specific receptor agonist. And when it compared with micronized progesterone, this has better bioavailability and the dosage is less when compared to that. And micronized progesterone, it has sometimes causes cholestasis in pregnancy, and there is no improvement in the live birth rate in cases of unexplained RPL. So the dosage will be 10 mg BD till 20 weeks, and for micronized progesterone it is 400 mg vaginal. And meta-analysis of 3 studies showed that there is dydrogesterone is associated with 29% of reduction in the odds of miscarriage. So antiphospholipid antibody syndrome, the primary one, it has no connection with connective tissue disorder. The secondary one, it is associated with any connective disorders like SLE. So this phospholipid is a component of the cell membrane. It has 2 layers. One is internal and the other is external. The internal is facing the cytoplasm and the external is facing the blood stream or the tissue fluid. Sometimes when there is an ischemia or cell injury, the internal phospholipid layer get extruded, and that becomes antigenic and causes this antibodies production. So the mere presence of antibodies, antiphospholipid antibody, doesn't mean that they have the disease. So it requires a precipitating factor like pregnancy, oral pills, prolonged immobilization, or dyslipidemia, like that. It requires a triggering factor. The pathology is one of inflammation, thrombosis and defective angiogenesis. So in thrombosis, all 3 aspects are involved: the platelet, fibrinolysis and also the coagulation cascade. In defective angiogenesis, there is a hypovascular villi, more of syncytial knots, and there is decrease in vesiculosyncytial membranes, that is the area where the maternal and fetal exchange occurs. So when that is reduced, and the spiral artery remodeling is also defective. So all this result in decreased blood flow, resulting in placental infarct. So this is manifested as a clinically like early onset preeclampsia, abruption, IUGR and IUD. So the clinical criteria are, there are 3 states. Either there will be spontaneous consecutive unexplained miscarriage less than 10 weeks, or there may be one or more spontaneous miscarriage, the fetus will be morphologically normal. The third one is there may be one or more premature labor of a morphologically normal fetus. One of these may be there, and again there must be one clinical criterion and one lab criterion to label them as APA positive. In diagnostic tests, there are 3 tests. One is anticardiolipin antibodies. Here the cutoff is 40 units, IgM or IgG. Then other is the lupus anticoagulant. This is more specific but less sensitive. And APTT is one thing that is more significant. The other is DRVVT, then kaolin clotting tests. Usually, at least 15% when the APA tests are positive, 15% will be, one of these tests will be positive. Most when 2 tests are positive, the anticardiolipin antibody and the lupus anticoagulant will be positive in 85%. The third one is beta 2 glycoprotein 1 antibody, and this will be not that common. It will be seen in 11%, but it is very highly prognostic because once that is positive, it has a very low rate of live birth rate and higher incidence of preeclampsia and other conditions. So if the test is positive, we have to repeat it after 12 weeks. And if that is positive once again only, then we need to label them as APA positive. If that is negative, again wait for 3 months and do it again. So the medical management will be low dose aspirin, 75 mg, start when the pregnancy is confirmed and continue till the beginning of 9th month or 1 week before the planned delivery. And it's supposed to increase the success rate by 40 to 80%. The second one is heparin. These can be unfractionated heparin, 5000 units twice a day subcutaneous, or low molecular weight heparin, 40 mg daily, once daily subcutaneous. In the low molecular weight, it is expensive, but when it is given, periodic platelet and APTT must be monitored. So, and this can be taken till 1 day before delivery, and after delivery it can be stopped. So, as together aspirin and heparin, the outcome is good in 80%. So, to conclude, evaluation and treatment must begin before pregnancy. There must be physical and mental preparation is a must. Physical preparation by way of exercise and diet, and mental preparation, they must be counseled. The patient, the prospective mother must express her doubts, fears and anxiety, and if it will be better if she has a mentor at home. And also the rapport between the treating doctor and the family should be very good before pregnancy and during pregnancy, so that as and when the improvement occurs, any problem identified, it can be discussed very well and they'll take it in the right sense. And with vigilant monitoring during pregnancy with good neonatal backup, it improves the success rate. Thank you.